Dermatology, and I don't have anything to disclose to the audience that is, I think, relevant. We have as our guest speaker Dr. Vicki Werth, who is a professor of dermatology at the University of Pennsylvania in Philadelphia. She also is at the one of the Philadelphia VAs. I've known Vicki I was looking back at Dr. Werth's CV, and I think I first met Vicki at a meeting that we were mutually speaking at in, I think, about 1990. So it's a little bit over 30 years. I think that was the first time that we met.
Wow.
Dr. Werth has trained medical school at Johns Hopkins. She then went to Northwestern University, where she did a medicine internship and residency, and then decided to go into dermatology, did her residency at New York University. She then went down the East Coast to Penn and has been there, I think, ever since. She is a funded NIH-funded researcher, has many grants and things like that. She has focused on the skin as a manifestation of internal disease and has a specific focus in cutaneous collagen vascular diseases, including lupus, dermatomyositis, scleroderma. She's focused primarily on cutaneous lupus and dermatomyositis, and lupus is what we'll be hearing about today. She also has an interest in blistering diseases of the skin, and has written extensively on all of these diseases. Let's see. Other than that, I have no other announcements. I would remind people that that dermatology is. I've heard in the past from several people in our evaluations that you have a difficult time finding us and finding us for referring patients to us. And I'll say it now, and I'll say it again maybe toward the end before the Q&A. We are open and willing to see all of your patients who you refer us. If you have any difficulties, please send me an email and let me know what difficulty you encounter, and we will see your patients. My email is jeffrey.callan@louisville.edu. So without further ado, I should also tell you about Dr. Werth, that she has been awarded with many teaching awards, including most recently she was given the Dermatology Foundation award for excellence in teaching, which is a once a year award. It is really a big honor. That's her, I think, most recent award that she's received. Now I'll turn it over to you, Vicki. We're going to hear a little bit about cutaneous lupus today. Go for it.
Great. Well, it's great to be with all of you, and I'm going to be talking about cutaneous lupus, and we're going to talk about the different phases of the disease and also different approaches to evaluation and therapy. I do have some disclosures, and this is actually good news because there's interest now in the skin manifestations of lupus and dermatomyositis, and that leads to the ability to get new treatments, which we desperately need at the current time. I've also been involved with developing an outcome instrument that's being used in a number of international trials now, and it will help us, I hope, get some better therapies. So I wanted to start with a case. And this is somebody I actually just saw a couple of weeks ago for the first time. A 60-year-old Caucasian female, history of SLE for 10 years. It started with a rash on her hand and arthritis in her fingers, and then some serologies were done, and she had a positive ANA of 1 to 640, positive SSA, and a negative double-stranded DNA. And you probably know that we worry about if there's a high double-stranded that there's more chance of renal disease. And an ANA is not specific for lupus, but it sort of makes you think more about a disease in the collagen vascular category. So she had a low titer IgM anticardiolipin antibody, and it's more the IgG, again, that you worry about in terms of clotting, but she had an IgM and low titer, so not so worrisome, and no family history of autoimmune disease. So her treatment up until now had been going on for a while, actually. She was on some hydroxychloroquine, which is a fairly standard approach for SLE and is thought to prevent progression in a number of patients to more severe SLE. And we also use it to treat skin. And she'd also been on MMF. She flared every 3 to 4 years, and that at those times she would get some steroids and some adjustment in her therapies, but these have been her basic therapies. She'd had in 2016 3 biopsies that showed interface dermatitis, and this is a finding that we see in cutaneous lupus. We also see the same finding in dermatomyositis, and we'll talk more about that later. She had been on omeprazole intermittently over the years, stopping 6 months before I saw her, and she flared in July when she was on vacation and was given at that time prednisone, pretty high doses, and tapered over 6 to 8 months, as well as azathioprine. And she did have a low white count. She was anemic, but not iron deficient. And again, anti-double-stranded was normal complements, no protein in her urine. So she flared again in early February after she had finished tapering. And at that time, she was switched back to MMF from the azathioprine and added Medrol at a fairly high dose, 24 milligrams a day. And then about 2 days before I saw her, she was bumped up to 48 milligrams a day, which is 60 milligrams of prednisone equivalent. And she was referred in. So this is what she looked like. And the things that you should notice is that, first off, it's photo-distributed to a certain extent. It's the V of the neck. It's also the lesions, which are erythematous, somewhat psoriasiform, but there's also somewhat of an annular quality in that there's some clearing in the middle, maybe some little bit darker areas here. There's also on the extensor arms, and as you can see, nearly confluent over her whole back with crusting, and it's a really extensive disease. And you can see why the decision had been to give her lots of steroids. So this is what she looked like 2 days before I saw her, at the time that she had been on 24 of Medrol, bumped up to 48. And then 2 days later when I saw her, you can see less red, less scale, but probably more scale, but not as much crusting. And, maybe getting a little bit better, but still, doing not great. So her skin biopsy showed subtle interface dermatitis and increased dermal mucin, which is this sort of bluish material, which you can see in the second layer of skin. This is the epidermis here, and typically that would be made by fibroblasts more in the dermis. And also she had a negative direct immunofluorescence with no immunoglobulins, so no IgG, no IgA, no IgM or C3 at the dermal-epidermal junction, which would be here. So that was all clear. And we'll talk more as I go through a few more things later. So her diagnosis is subacute cutaneous lupus. She, and we'll go through the different subtypes so you'll see sort of where that fits. And she has more of a photo-distributed psoriasiform lesions, but there's a hint for some of them being a little more annular, which is another variant that you can see. She had a positive SSA, which at high titer you can see in Scle. And people think of this as the Sjogren's antibody, but we see it a lot in people who don't have Sjogren's. So I almost feel like it's a misnomer because we do see it, in other forms of connective tissue disease. But at very high titer, it fits with that diagnosis of Scle. The biopsy shows interface dermatitis. She's, older, which is, we think of our lupus patients as being younger, but when they start to be like she wasn't, 50 or up, you have to start thinking, that is typically what we see in subacute cutaneous lupus, and so she fits that way. And she's using this drug, omeprazole, which people can actually get over the counter even, and so you have to really carefully talk to people about what they're getting because it's, maybe they're getting prescribed higher doses, but it's often even the lower doses that can be a trigger. And so, taking a drug history, and we'll talk about some of the drugs that can be involved in this kind of patient is really important in getting them to stop. So I'm going to talk today about these 4 areas, namely the quality of life, the clinical heterogeneity, just a touch about pathophysiology, and then evaluation and treatment. So this is what the skin looking at quality of life using something called the Skindex, which can look at symptoms, emotions, and functioning parts of quality of life. And what you can see is that the highest scores are often in the emotional realm. And in the case of lupus, which is in blue, they're higher than many of the other conditions. And the patients really have poor quality of life, particularly in the emotional area. And another index called the SF36 is a way that can be administered to other, it has non-dermatologic aspects of it as well. So you can look at other diseases like congestive heart failure, type 2 diabetes, recent myocardial infarction, relative to CLE. And what this is showing you on all these areas in yellow are areas where the patients who have these significant medical illnesses are actually doing better in their quality of life relative to patients who have CLE with lower scores. And so what do these quality of life scores where they're doing worse in CLE represent? Well, it's social functioning, role emotional, mental health. So the quality of life is poor, and there's really good evidence that many of our patients with cutaneous lupus are really having major issues. So clinical heterogeneity, well, so there are a number of lupus-specific skin lesions. And if you break them down, it's chronic cutaneous, subacute cutaneous, and acute cutaneous lupus. And under chronic cutaneous, there's discoid lupus, tumor peniculitis, and tumor LE. And so this is a little bit of a wastebasket because the pathologies are quite different sometimes, or usually. And but in discoid lupus, even clinically, you can have either localized lesions above the neck, generalized above and below the neck, or thicker elevated lesions, which are hypertrophic, and we would probably call them more like plaques most of the time. So in subacute cutaneous lupus, you can have psoriasiform or annular polycyclic lesions. And in acute cutaneous lupus, they have malar erythema and a photodistributed erythema. And this looks quite different often from these other subsets. So I'm going to go through and show you what these look like. So this is localized discoid lupus. And you can see erythema here, you can see scale, there's dyspigmentation, there's atrophy, the depression in the area where there's scarring. And so this has a lot of attributes that are concerning for patients. And so you can get the patient better, but they're still going to have some residual problems. And it turns out, luckily, that it's mostly the erythema and scale that are bothering the patient more than the scarring. And so if you can improve activity, their quality of life by measures does improve. If you look at the biopsies, you see again this vacuolar alteration with sort of this whitish areas that are, vacuolated, sort of necrotic keratinocytes, just usually at the bottom of the epidermis, this being the epidermis up here and the dermis down here. But you can also see lymphocytes that are around hair follicles, vessels, and also at the dermal-epidermal junction. And these are all things, along with the mucin, that are pretty characteristic of patients who have an autoimmune, either lupus or dermatomyositis. So if you're thinking about lupus, it's okay to say, okay, this looks a little like a discoid, some erythema here, and this looks different in darker skin, but so you have to be tuned into the erythema that is here. But in addition, then you might want to look in the ears where there's some dyspigmentation, erythema in the conchal bowl, and there's also lesions in the scalp, which are causing what will be likely permanent scarring. And so this is a good area to look at for the clinical findings. And this is what happens in the scalp. If the lesions don't respond to treatment or if they're not treated, they can develop more permanent, there is activity here. It's pink, there's some dyspigmentation, and there's still some areas that are a little bit more active. But in general, these are getting to be a little more burned out, like up here, meaning that there's not any erythema, no scale, and it's just kind of, dyspigmented and fairly burned out. And so the hair is not going to likely regrow in these areas. And earlier on, if you were to look at an area like this, you might see lymphocytes around hair follicles, and it looks active. And so that's something you can treat, and we'll talk a little bit about treatment. But this is an area that you could treat. Up here, if somebody just looks, like it's burned out, it's a little bit too late. And on direct immuno, and I must say we don't do a lot of direct immunos because usually it's the clinical and the histology that I just showed you on H&E that we look at. The DIF is, you can see things. You can see that these immunoreactants like IgG, IgM complement at the dermal epidermal junction. It can be like a granular pattern. But the issue is that you can have false positives, and actually Dr. Cowan has published about how in photodistributed skin, 20% of the time. In people who do not have lupus, you might have even some immunoreactants. And so, we use this in certain very specific situations in lupus, but it's very helpful in other skin conditions to do a direct immunofluorescence, and more so than probably most of the time in lupus. And this is generalized discoid lupus, so you can see below the neck. Again, you might look at this. This could be a lot of different conditions, and so you'd have to, probably look at histology and look around in other areas. But when it's above and below the neck, that's when you start saying this is more generalized. This was a patient with discoid lupus, and it clearly got much better, more hypopigmented now. But there's this one residual area that did not get better. When we biopsied it, it was a squamous cell carcinoma. And you can get scar carcinomas in these kind of areas, in the areas that had discoid lupus. These are examples of more the rolled border and elevated lesions that you can see in hypertrophic discoid lupus. And the treatments are the same. It doesn't change the prognosis. It just looks different. And so, in general, we recommend doing a biopsy because there are differential diagnoses that can be thought about beyond lupus from the clinical presentation. And so a biopsy is helpful in confirming that it could be something like lupus, and that's very true for hypertrophic discoid lupus. Another example of hypertrophic lupus, you can see that there's some pitted scarring here, which can happen, and there's still lots of areas that are a little more hypertrophic and scaly and so on, but this is, again, another example of rather severe hypertrophic lupus. Now, we know that oral ulcers are seen in SLE, but we also see them in discoid lupus and really other forms of cutaneous lupus. So you can see there are erosions in the nose here. There are certainly erosions in the mouth. Typically, it's on the palate, but you can see them in other areas. You can see here there's some erosions here on the gingiva. And so it's good to look in the mouth also, but it won't tell you is this SLE or just a variant, a part of the cutaneous lupus. And then as part of chronic cutaneous lupus that we talked about is lupus peniculitis. And here the histology is actually in the fat. And you can see lobular, the fat lobules have inflammation, this bluish areas in fat lobules. And sometimes you'll see overlying discoid lupus. But here's what happens in peniculitis. As it resolves, you get this lipoatrophy and can cause a lot of disfigurement for patients. So again, rather cosmetically sensitive area. And tumid LE, you get this mucin here. You get often lymphocytes around the vessels and around hair follicles, but not at that dermal epidermal junction as much. It's usually not there. And here you can see erythema, and it's non-scarring, but very distributed types of lesions that occur. So we just covered chronic cutaneous lupus, and as you can see, pretty heterogeneous clinically. And so it is difficult very often to look at a patient and know for sure because it's hard to remember all those different clinical patterns. But we're not done, and we have subacute cutaneous lupus. And here is an example of the annular polycyclic types of lesions that occur often in photodistributed areas like the arms, the V of the neck, on the upper back. And this is more like our patient, right, who had in the V of the neck, but obviously other areas, more psoriasiform type lesions. And again, a biopsy is going to show you interface dermatitis here. Now, if you were to do a direct immuno of such a lesion, what you might see is these punctate areas in the epidermis. Again, this is the epidermis. This is the dermal epidermal junction. And what happens is the SSA antibodies can bind in the epidermis and give this kind of punctate staining, which is actually not typically reported out on biopsies, and so it can be missed. And so when they said that her biopsy direct immuno was negative, we don't actually know what the story was in the epidermis, and there may have been this kind of staining pattern. Now, I emphasize the importance of drug-induced SCLE, and I bolded here the kinds of things like with omeprazole, and really it's a class effect. So the PPIs in general, if somebody reacts to omeprazole, they're going to react to the other PPIs usually, and that makes it really tough for patients with GERD. But there's a whole other group of drugs that are implicated, the TNF inhibitors, Lamisil, and some of them really work very quickly. So you might start Lamisil, and 4 weeks later, the patient may have a full-blown case of subacute cutaneous lupus. So you have to keep this in mind and always think about drugs that can be causing, in particular, subacute cutaneous lupus. And then we'll talk about acute cutaneous, and here's an example, which is this is a malar rash, obviously extending up into the forehead, but you can see that there's sparing of the nasolabial fold. There's involvement pretty much in a lot of different areas, but this sparing is rather typical of acute cutaneous lupus, and in dermato, they can look kind of similar, but they tend to have involvement, have erythema in the nasolabial fold, and so that's something to look for in these kinds of patients. I wanted to just, by contrast, talk about dermato, where you tend to, if you see a malar rash like I just showed you here, look at the hands, because if you see this with erythema over joints, over the MCPs, the distal and the proximal interphalangeal joint, that's probably going to be dermatomyositis, because in lupus, and I'll show you a picture of that, the erythema tends to be more between the joints, so more in this area or between in here, but not targeted only to the joint. And this is looking at more of a Shaw sign, which is on the upper back. So again, some contrast. So we saw our patient with SLE with sparing. These two patients, you can see there's involvement really in the nasolabial fold here. There's erythema throughout the whole face here. It's very violaceous often, more violaceous than dermato. And then if you look at the hands, again, targeting of the joints, over the joints, specifically in DM. But here you can see in lupus, it's really more between the joints and the sparing of the joints. So I think that's just a rule of thumb. You have to still take other things into consideration. But I think it's really important to look at hands. And also, you're more likely to see these kinds of nail fold telangiectasias in a patient who has dermatomyositis relative to lupus. So you can look at that area as well. And then Bolus Lupus, you get these tense blisters, and they're usually neutrophils. So before I showed you lymphocytes, these are neutrophils, and you get a blister that splits the epidermis from the dermis, and then the kinds of treatments that we tend to use are a little bit different for this condition. And when you do a direct immuno, which is actually quite helpful here, you'll see immunoreactants at the base of the blister cavity. So this is the whole blister, but sometimes in some blistering diseases, you might see the staining with the green stain up here, like in bullous pemphigoid, but in lupus, it's going to be down here, and it'll be linear. And so that's a really nice thing to look at. So at the end of the day, after looking at all these different variants, one can think about, well, what is the prognostic significance in terms of getting systemic disease? And here's skin disease only, here's systemic disease patients, and it's a continuum. And I like to think of lupus as a continuum and not split it into CLE and SLE, because there are a lot of CLE patients who have a little bit of arthritis that's related to their lupus, and they might be a little bit like here along the line. But many of our patients, and let's say all, but many of them don't have, horrible systemic disease. And so localized DLE, hypertrophic LE, lupus peniculitis, and tumate lupus are more on the skin disease part of the spectrum. If you have generalized DLE, probably 20% of those patients meet criteria for SLE, probably closer to 40-50% with SCLE. And then if you're dealing with a patient with acute cutaneous lupus or lupus nonspecific disease, and that would be, for instance, like a vasculitis or urticaria or livido, then those patients are often more likely to have a systemic disease. And so, it's a window into the skin. Many of the patients are not going to have systemic disease or not severe, but some of them will. And so that guides our workup that we'll talk about. So in terms of interface dermatitis, so what happens here is that there are interferon-inducible proteins and that are elaborated by the epidermis. And it's right in the area where you see these CXCR3 positive lymphocytes. And interferon-inducible CXCL10 is expressed in the areas where cytotoxic lymphocytes invade the basal epidermis and cause keratinocyte death. So there's a lot of crosstalk between the epidermis and these cells that come into the skin or in the skin to be really at that dermal interface. And here you can see, for instance, MIX-A, which is an interferon upregulated protein, also CXCR3, CXCL9, and CXCL10, and these are interferon upregulated chemokines at the dermal epidermal junction. And these are the inflammatory cells that you can see. But anyway, many of them are type 1 interferon upregulated, and these are just showing you some of the pathophysiology that goes on in bringing these inflammatory cells to the skin. But it's not just the skin, in the blood also. For instance, in Scle and Discoid Lupus, there is an interferon score. You can look at a number of genes that are regulated by type 1 interferons, and they're elevated in some of the subtypes of cutaneous lupus, in particular those who have interface dermatitis. So Scle and DLE, we don't see it in tumid LE where we don't get interface. It's seen in acute cutaneous lupus, but not in normal healthy controls. We've developed this disease severity tool, which I told you could help measure activity and damage and give you at the end of the day, after measuring things like erythema and scale hypertrophy and a number of different body surface areas, looking at the hair and so on for activity and damage. You can get an activity score and a damage score. And this is a very objective way of trying to get to how much activity is there and does it get better over time and what interventions have helped. And we've spent about, I guess by now, 16 years doing validation studies. These are some of the early studies to try to show that this might be a helpful index. What this shows is that the interferon score is correlating with the activity score. And so if you have a high interferon score, you're more likely to have bad skin disease. And so you can imagine that some of the new therapies that are coming along are targeting things like interferon with the idea that it may be helpful for both SLE and for skin. So who gets refractory disease? Well, we know that patients who have generalized discoid lupus are more likely to have refractory disease, and also patients who have hypertrophic DLE, whereas patients who have localized DLE or SCLE are less likely to have refractory disease. And refractory disease just means they're not responding to typical therapies, which we haven't really talked so much about, but it can be antimalarials, it can be immunosuppressives. And so again, the patients who have generalized discoid or the ones with hypertrophic just don't seem to respond quite as readily. We also know, and I like to use as ammunition for my patients, that smoking is really bad for both SLE and cutaneous lupus, and that patients who have refractory disease are more likely to be smokers. Like, this is almost 75, 76% of people who have refractory disease are smokers, relative to a much lower percentage who are not refractory. And so sometimes we don't have as good data to say if you stop smoking, you're going to get better. But we can certainly say that smoking is a bad thing. All right, so evaluation and treatment. So in terms of the history, I think it's really important looking for, are there triggers? Are there any systemic symptoms? Also looking at the physical exam is really important. To look not just the skin, but is there adenopathy? Are there other things that are going on here? A skin biopsy is very helpful to confirm the diagnosis in general, because often these patients are going to they may respond to topical meds, but if you're going to go to systemic meds, it's really helpful to be really competent in the diagnosis as well, and the histology can contribute to that. The labs we check in a patient where we're suspecting lupus might include ANA, a CBC, a CMP, and a urinalysis looking for protein or even hematuria. And if you see proteinuria on a urinalysis, that's needs to be evaluated and quantitated much more carefully. So if there's definite evidence of systemic disease, these are some of the other tests that we might think about. You might get the SSA, SSB earlier in the game, especially if you're thinking about SCLE. But in general, for quantitating urine, we're using a urine protein to creatinine ratio, and we work closely with nephrology. For instance, if somebody has lupus nephritis, they may need a renal biopsy and a different approach to treatment. So in terms of the skin, usually we think about the sun as a trigger. Excuse me. And so you have to avoid the sun. You have to use sunscreens and sun clothing, protective clothing, some of which is marked for SPF, can be quite helpful. And so this is really important, not to have your patients out on a beach, at noon in August. And then stopping smoking, we talk about. These are some of the topicals that we use. There are different variants of topical steroids that can be used, class 1 being the strongest. And we don't tend to like to use class 1 steroids on the face because they can cause a lot of atrophy and problems. And we use them for short periods, as short a period of time as possible in general, and then to go down to lower concentrations of steroids or that will have fewer side effects. And then there are these non-steroidal creams and ointments such as pimecrolimus and tacrolimus, which can also be effective in lupus. These are usually more helpful as adjunctive therapy, but for milder disease, you can also use it as one of the primary approaches to treatment. The antimalarials are first-line therapy, and we use hydroxychloroquine and chloroquine, not at the same time. We start with hydroxychloroquine. We're carefully dosing. We don't want to overdose patients because there is a risk of eye toxicity. So this is nowadays usually dosed according to actual body weight, less than 5 milligrams per kilo per day. And if the hydroxychloroquine doesn't work, and it can take often 2 months to start to work, then we'll switch sometimes to chloroquine. But this has more eye toxicity. And so we may not want to use it, or if we do, it may work in some patients. And then if these don't work, we'll move on to immunosuppressives, which could be things like methotrexate or azathioprine or mycophenolate. Azathioprine doesn't work that well for skin, and so I kind of favor methotrexate if they don't drink or don't have fatty liver. And otherwise, MMF, which is Cellcept or mycophenolate, would be kind of a drug that we do use. And then the next sort of going down is thalidomide and its derivatives, and we'll talk more about that. And then other agents that we'll talk about are listed here as well. So the evidence for antimalarial use is pretty good. One of the studies that was done looked at how many responded to hydroxychloroquine when they had CLE, and it was around 55%. So it's not everybody, and that's unfortunate because it's a pretty easy drug to use. It doesn't have hydroxychloroquine doesn't have that many side effects, and essentially they need monitoring for their eyes, and that's pretty much one of the main things that has to happen. We used to use quinacrine until it went away, no longer available in the U.S., but it worked in a lot of our hydroxychloroquine refractory patients. And in fact, in one small study, it was like 2/3 of them got better. And here you can see their scores coming down very quickly after they got onto quinacrine at time 0 here in the responders. And even the non-responders were trending down. And so it's rather unfortunate that quinacrine went away, and we're hoping to get it back at some point. But it's also provided an opportunity to understand more about the differences in the skin, which is an area that my lab is working in, between patients who respond to hydroxychloroquine and those who respond to hydroxychloroquine and quinacrine. And so what you can see here is that we stained either with CD11C, which is staining more the myeloid DCs, or CD123, which is more the PDCs. And you can see we have pretty equal numbers of PDCs between hydroxychloroquine and hydroxychloroquine quinacrine. But in the case of the patients who needed quinacrine to get better, they tend to have more of these myeloid DCs. And so there was quite a difference here. And when we looked at the signatures in the skin, what you can see is actually there were differences also in the sense that the patients who responded to hydroxychloroquine tended to have more of a type 1 interferon gene expression. So this is looking at different type 1 interferon genes in these different panels. And as you can see, in most of them, the type 1 interferon is higher than what we saw in the patients who required quinacrine. And that was really true across the board. And it was the opposite of what we saw pretty much with TNF expression in the skin, where it was higher in the patients who responded to quinacrine as opposed to hydroxychloroquine. So this speaks to the idea that there are different cells and different signatures in the skin, and one has to start to think about targeting therapies as we get better therapies along the way, because there are going to be differences between patients. And many of the differences are more related within for a subset, like within discoid lupus, than even between subsets. So there really are differences that are hard to account for by knowing that they have DLE or SCLE. So we're going to move on and talk about immunosuppressives. And there isn't a whole lot of data. There's some case series. We did one study looking at quality of life in people in our database who were started on immunosuppressives, and about half of them responded. As I told you, I think methotrexate and mycophenolate are probably more effective. And here you can see among the responders in the skin, the quality of life comes down very nicely, whereas in those who didn't respond in terms of activity in their skin, there was no improvement. And then that brings me to thalidomide. And in thalidomide, we have pretty good evidence from case series, but here's one with 60 patients that it's pretty effective. And improvement starts pretty quickly with full effects in 4 to 8 weeks. And it's the highest response is in SCLE and DLE relative to lupus profundus, which is only 50%. And there was no difference among these other different subsets. And it turns out when you back off on thalidomide, there's often a high rate of relapse, especially in discoid lupus. But in SCLE, the relapse rate is lower, which is interesting. But it's higher in discoid lupus. Responds to retreatment, often requires some form of maintenance, which may not be that much. It might be 1 or 2 pills a week. And then the side effects, though, are really the problem because they often get peripheral neuropathy. It's a highly teratogenic drug, and so they need to be on 2 forms, highly effective forms of birth control, and have regular screening for pregnancy. So this drug is not to be taken lightly. But this is the kind of effect you can see before and after thalidomide. We became interested in analogs, which are more potent and potentially less likely to cause a peripheral neuropathy, and they already were used for myeloma and myelodysplastic syndrome. So we did an open-label study with 5 patients, and this is looking before and after. And this was a patient who hadn't responded to anything previously and was very unhappy with their disease. And you can see within 6 weeks that her activity went down more than 50%, and she was much happier. And her biopsy, you can see she has much fewer bluer cells here in the, was before, and then after, it's harder to find the lymphocytes in her skin. And looking at the 5 patients, 4 of them trended down pretty well. 1 of them stopped because they weren't getting better. Then this study with 15 patients showed an 86% complete response rate. And as you can see here, again, using a skin score, that the rate of decrease is really quick in this group of patients. Again, nice to have a drug that can really have a rapid onset of action. I will tell you that lenalidomide, which is the one that's on the market for myeloma also, and myelodysplastic syndrome, costs $650 a pill. And they were interested in developing this for an inflammatory indication and losing that kind of reimbursement for medication. And so we use lenalidomide, but normally have to fight very hard to get it. But it's quite effective. It has the same issues as thalidomide in terms of potentially increased risk of clotting, which is another one I didn't mention, but less peripheral neuropathy. And teratogenicity is still a problem. So now there's a new drug that's developed by the same company called iberdomide. And this one has effects on Ikaros and Aiolos, which are zinc finger transcription factors involved in immune cell development. And they are overexpressed in the blood, in the PBMCs of patients with SLE, and there are polymorphisms in these 2 transcription factors that are associated with an increased risk of developing SLE. So this is a novel high-affinity ligand of cereblon, and this iberdomide binds to cereblon and induces clearance of these 2 zinc finger transcription factors and reduces the protein levels in B cells, T cells, and monocytes. And it's been screened to be more potent than thalidomide or lenalidomide. So some recent data that has been developed and presented at ACR indicates that the patients overall who responded well to iberdomide at the highest dose, and you can see the response was pretty much not there relative to placebo in lower doses. And this heightened response was seen in interferon high patients, and in Aiolos high in particular, it seemed that those patients who were Aiolos high seemed to respond, and that speaks to the mechanism of the drug. With DLE, there wasn't quite the same effect, which is interesting. And so and we can see here that there was some improvement overall, but it didn't seem to sort out with those who were interferon high or Aiolos high. And a little bit with Aiolos high, I would say. So there's still a lot to be learned, but this is the beginning of some studies that I think will hopefully provide a more consistent access of our patients who are really severe to improve therapies. Now, Bolus lupus, as I told you, is neutrophilic, and dapsone blocks neutrophil migration and is effective for neutrophil blistering conditions. And there are reports also, if the dapsone isn't working or if the patient has bad SLE, you might want to think about something like, and if they don't respond to like steroids and immunosuppressives, rituximab may help. And so this knocks out the B cells that are making the anti-type 7 collagen that is pathogenic for refractory bullous lupus. However, rituximab also can exacerbate DLE and SCLE, and it doesn't seem to help the skin. And this study here, there were 82 patients who got rituximab, and 32 had significant skin disease before or after treatment. And only 40% of the patients with baseline skin disease had a beneficial response. And of the ones who responded, it was mainly the patients with acute cutaneous lupus, not with discoid lupus or SCLE. So I try to advocate for, if they're trying to treat the skin and the patient's refractory, probably not to think about rituximab, because in addition, there were flares of SCLE and CCLE in 12 patients who had no skin disease or ACLE at baseline. So that's concerning, and so it's probably not going to be the answer. There's Bilimab, which has been approved now for a while for SLE, and this is a drug that basically has effects on its anti-BLyS monoclonal antibody. It has effects on mature B cells and blocks their development. And there was a 10% difference between a placebo group and the treatment group in one study. And so what you can see here is that this is the effect on skin based on it went away or not on one skin score. And this is placebo. So there was some improvement, but it took a long time in later studies where people have looked at that. And I certainly see a lot of patients where it hasn't helped very much. But for some patients, it might be an approach. So what are some of the newer treatments? Because I think we're now entering a new era. Is more targeting some, like for instance, the type 1 interferon. And so there's a drug called anifrolumab, which is interferon receptor monoclonal antibody, or IFNOR, and there's also anti-BDCA2. We'll talk about each of these in PDC, and there's a huge number of approaches in the pipeline now, so it's a very different time. So and now you can see we're not doing case series, we're actually doing randomized placebo-controlled trials, and so this is looking at patients with SLE and looking at the skin and looking at anifrolumab, which is this anti-IFNOR antibody. And this is a placebo relative to 2 treatment arms. And you can appreciate the placebo group. You know, there's always a placebo response, but it didn't respond nearly as much as the 2 treatment groups. And this is the kind of response that was seen. And unfortunately, they did not characterize the type of skin lesions in lupus, which I think will be an important thing to implement as more trials are done. This drug did block the interferon signature quite well. And you can see the orange is where they were getting the drug, and the interferon signature comes down, and then when they stop getting the drug, it goes back up again. And then they actually went to a phase 3 trial, and here you can see placebo relative to drug and looking at the percent responders, and there was a difference when they looked at week 12, which was the predetermined time to look at skin. There was a significant difference between the 2 arms here. Twice as many responders in the treatment arm had a greater than 50% reduction in skin activity. Now, another approach is looking at PDCs, which are abundant in skin. These are staining here in purple. And in CLE, type 1 interferons are made by PDCs among other cell types, and they amplify the lesional inflammation. And PDCs are activated by Toll-7 and Toll-9, so RNA and DNA, and they induce interferon-inducible chemokines and recruit T cells into skin. So PDCs can be measured with this BDCA2, which is present it's a surface marker. So this drug, BIB59, actually binds to BDCA2 and causes internalization of the receptor. And that downregulates pro-inflammatory chemokines, some cytokines that might be important, and type 1 interferon and type 3 interferon. So it has a lot of different effects on the PDC and its products. So they did a study looking at baseline and then after only one sub-Q injection at 4 weeks. And what you're seeing here is that there were some responders and then a few non-responders. The non-responders did not show a difference in their type 1 interferon mix A. So this is a mix A is a protein that's upregulated by type 1 interferon. And you can see between baseline and week 4, there's no difference. Whereas over here in the responders, there really was a difference, and it correlated with the decrease in the skin score. So I think, and then here you can also see that the amount of inflammatory cells measured with CD45, in the one patient that was a non-responder, you can see there was no effect on CD45. And so this drug doesn't work in everybody, but in the ones that it works in, it's pretty exciting. And they're going to hopefully go on to a phase 3 trial in the near future. And then so basically there was a phase 2 trial, and what was seen was that the skin score improved in 40.9% and 48% and 42% of 3 different doses relative to 14% of placebo. So again, a nice split between the placebo group and the 3 treatment arms of different doses. And so this drug seems to work for a subset of patients where PDCs are maybe a driver for the disease. There's another drug where there was a phase 1 trial with an anti-PDC, which is an antibody to ILT7. This is a very small study, but again, the same effect. If you look at baseline and at day 85, you can appreciate that the PDCs go away at day 85 after getting, the treated mix A. Look at the difference there quite a bit, and CD45. And so this is the placebo group at the high end, and this is, this is the treatment group at the high end. There was a lower dose and placebo group that really overlapped. And so it does look like there's some effect in some patients with this approach also, which is very similar to the one I just showed you before. So in conclusion, CLE has a large impact on quality of life. Cutaneous lupus has many morphologies. It's important to look for SLE when CLE is diagnosed and to follow patients to make sure they don't get SLE. Understanding the pathophysiology is important to knowing which treatment to use for a patient. And we have a lot to learn in this area, but in some patients, blocking type 1 interference and PDCs can be helpful. And it's a very exciting thought that we might be able to give an injection once a month and actually that has relatively few side effects and may be helpful. It's not going to work for everybody. And there are many new treatments in the horizon. So if I give this talk again in a few years, I think we'll have even more progress to discuss. And I think that's it. So I'm going to stop sharing, and I want to let Dr. Callan ask questions.
Okay, I'll get us started. So let me ask your opinion about. So you highlighted in subacute cutaneous lupus that drugs may trigger or exacerbate the disease. How often, in your experience, when the drug is taken away, does the disease completely go away versus patients where the disease is awoken up, or whatever is the proper English, and it doesn't seem to resolve even though the drug that seemingly exacerbated it is gone?
Right. I mean, there's no question that, part of the definition of knowing that it's drug-induced, right, is that, you stop the drug and they get better. So then it becomes difficult to know of the inciting drug did or did not actually trigger the disease. I don't have the percentage there. And I have the impression that there's certain drugs where it's more likely when you stop them, like a PPI, that they're going to get better. But there may be other ones that are like real triggers that it just doesn't get better. And I don't know why there's a difference. Clearly there is. But in terms of percentages, I don't know that. Do you have any thoughts about that?
No, I don't know, but there are some where clearly it occurred when the drug was begun, and it doesn't seem to go back to sleep.
Right.
And then if they get the drug a second time, like the PPIs particularly, we'll tell people don't give the patient omeprazole, and then they give them pantoprazole, and that seems to exacerbate it again. So I think there are people who have disease that is exacerbated, and there are people who maybe don't have disease, they get the disease, and then it brought it out, and they don't fully go back to sleep. But I don't know the percentage either. You talked about thalidomide as an option for treating the patients. Do you, in your practice, um, test them with nerve conduction studies? Do you test them as they're being treated?
So, I often will try to get more at baseline. And, the problem, of course, is some of these patients have baseline peripheral neuropathies, and they know that. And then it becomes really hard to know, you're looking at a decrease in their abnormal nerve conduction. That's why I almost don't use thalidomide now, because I find lenalidomide works so well, and I haven't ever seen a peripheral neuropathy, which I saw in almost all my patients eventually with thalidomide. So, I really do wonder if iberdomide may be a better alternative for us in the future.
Let's see. Dawn Castor has a question that she put in the chat about a role for calcineurin inhibitors in refractory skin disease. Do you want to comment on that?
Is that for oral or topical?
Systemic, oral, systemic calcineurin inhibitors.
I don't think we know. I mean, I don't love those that oral drug in particular. Just because if you're on it chronically, I worry about renal fibrosis and things like that. I think it does work for some patients, but I tend not to use it for chronic, because it'll come back when you stop. So I don't have a lot of experience with it, I would say, and there's not a lot of studies.
So people have used JAK inhibitors in patients with dermatomyositis, seemingly a somewhat related condition. Have you used JAK inhibitors for cutaneous lupus?
So I have not, but there was a study that was done with a JAK1 and 3 inhibitor that did not help in the skin. The patients admittedly have fairly minor skin disease, but even when this trial was a phase 2 trial, and it worked because their endpoint was a combination of skin or joint, and the joint was the driver. It didn't do anything for skin. So, I think the jury is still out on that. And I have a lot of patients who have gotten JAK inhibitors like TOFA for their dermato, and I don't feel like I get to see all the failures, so it doesn't work in all the patients either. And now there's a black box warning that's coming out more for TOFA in terms of, risk of cancer, risk of clotting, this and that. So it's got its own set of issues and problems. I think it'll be interesting to see where that therapy comes out in the future.
The patient that you presented at the beginning, you said had a low level of antiphospholipid antibodies. And does that impact your decision of whether or not to use the thalidomide or lenalidomide, since that's associated with potential clotting?
Great question. So if they had a high titer IgG and a history of, PE or DVT, I'd say I would never give it to them. Low titer IgM, which is less associated with thrombosis, I'd be a little less worried. I would certainly caution, let the patient know it's a potential risk. In the studies with iberdomide, they actually had to, in the middle of it, insist that people go on aspirin because they got concerned about it enough that they wanted to do that. And I actually find that a lot of my patients are on Plaquenil, which has anti-clotting effects also, but if they're not on Plaquenil, I put them on aspirin, and I really haven't had a lot of clotting. I haven't seen a lot of clotting in patients. But so I guess the answer is for this patient, I'd be happy to do it, except that, I think it's probably okay, but there are other patients I would never think about using it.
Okay. There are plenty of people still online. If you have questions, please unmute yourself and ask them, or put them into the chat and I'll ask them for you. I can't look at the chat and look at people who might raise their hands at the same time. I don't see anybody raising their hands, though, so I'm still looking in the chat if anybody has any other questions that you would like to pose for Dr. Werth. What about IVIG is what one of my residents, Rob Spalding, has asked for treating cutaneous lupus.
Yeah, I mean, that's a really interesting thought. There was one open label study that Sergio Grando did with IVIG and subacute cutaneous lupus, and it worked. I bet it would work. I mean, again, it's one of these things where are you going to park them getting IVIG every month? I mean, I think it's a good bridge. And for a patient like, I mean, it crossed my mind with this patient I presented because she was so severe, and the dose of Medrol was kind of crazy. So I thought of, in a way that if I couldn't get her, I wanted to give her lenalidomide. I'm not sure I'm going to be able to get it, but I think I might. Then I would give her IVIG otherwise to get her more comfortable because she was pretty miserable.
Do you have any tricks to getting people to stop smoking?
I tell them about the data. I'm so interested because I could never had any impact for years, and now I just say, look at these graphs, and I do have patients who will come back and say I stopped, and I'm like, I marvel, it's like, wow. So I think a lot of it is just emphasizing it, and there's some people that obviously will never stop, and they know, and they just obviously aren't even listening. So it has to fall on the right patient at the right time, but it's worth really trying.
Hey,
The other
Dr.
thing I would
Schott?
bring up is the immunostimulatory herbs. I mean, I don't think it's as big of an issue in lupus, but in dermato, it's a huge issue. And you should really steer your patients away from, there's really a growing list of things that I worry about a lot. And they include like spirulina, green algae, chlorella, but the list is ever growing. And it doesn't, the patients think, well, there's something wrong with my immune system. I want to take something to fix it, and they take an immunostimulatory herb, which is really not the right thing to do.
How about
And
echinacea?
even echinacea, yeah, but there's spirulina in everything. I mean, if you start reading the labels, it's
Mhm.
crazy.
Dr. Schott wants to know the dosing of lanalidomide.
So I typically use 5 milligrams a day. That's, I mean, they use higher for myelodysplastic syndrome. I really haven't had to go higher. The Mayo Clinic recently had a case series where they also had very good outcomes similar to the ones that have been talked about. And so I think, 5 milligrams tends to work.
Hey, Jason, you want to do the little presentation we have? You have to unmute, Jason.
All right, Dr. Werth, we started a tradition several years ago for our visiting visiting lecturers that we get a little gift for them, and even in the age of COVID and virtual meetings, we've continued that tradition. So UPS will be delivering something to you probably sometime next week, a little token from our great city that's very familiar with our city, and that will be your own personalized Louisville Slugger bat. So, so
That's great.
yeah. So we've been doing this. I guess our previous chair, Dr. Jesse Roman, started this tradition several years ago, and we've continued it on through. And so you'll be UPS person will be visiting you next week with a nice little gift from the University of Louisville Department of Medicine.
Oh, that's really sweet. Thank you so much. Yeah.
Thank you for a great talk today. Dr. Cal, you want to have any parting words or?
No, I guess I'll part for those of you who are still online. If you have dermatology consults that you need and you have any difficulty finding us, email me, jeffrey.callan@louisville.edu, and I will adjudicate that and we'll get your patient seen in a timely manner. And thank you for your attention, and thank you, Vicki, for being with us today and giving us this great talk.
Thanks, Jeff.
Thank you, everybody, and again, great talk, and thank you, Dr. Callan, for you always invite the best guests, and we really appreciate that. And we will be back again next week, 8 a.m. next Thursday. Actually, our talk will be from the pulmonary division, so we have a guest. They just sent me the name, got the name, and I cannot remember just off the top of my head, but it'll be, I know we will have a great pulmonary talk next week. So again, thank you, everybody. We'll see you next week again, 8 a.m. next Thursday, and we'll do it again. So thank you, everybody.
Bye, Jason.
Okay. Take care, Dr. Callan. Good to see you.